Ash, you can
Yeah,
start.
go, sir.
A very good afternoon and good evening to all of you. I welcome you all to the second season of the STAR webinar. The STAR webinar series we started in 2023. The concept behind the STAR webinar was to initiate best practice sharing in the field of epilepsy management. And in 2023, we have collectively seen participation of 2,000 doctors who attended these series of webinars across 10 different geographies. More than 25 doctors participated in this event as active resource persons, be it as a speaker or as a panelist. And very interestingly, we saw best practice sharing representing different types of epilepsies, starting from status epilepticus to tonic-clonic seizures, atonic epilepsy, and also resistant epilepsy, completing our acronym of STAR, STAR. For season 2, we decided to take this a notch higher and decided to include comorbidities in epilepsy as one of the major topic. And to start with our series of this year, 2024, the first topic is stroke related seizures and epilepsy. Ladies and gentlemen, as you all know, stroke represents the leading cause of morbidity and mortality worldwide. It is the leading cause of morbidity and mortality worldwide. And stroke related seizures and epilepsy is a complication associated with stroke and also traumatic brain injury that a lot of stroke physicians find it difficult to manage because of lack of very strong evidence, lack of guidelines, and therefore it is important for us to understand from experts how to manage such a condition. Therefore, to talk about stroke-related epilepsy and seizures, we have a very eminent stroke specialist with us today, our very own Dr. Arvind Sharma. Many of you know him as the conceptualizer of Neurospace, an event which has been successfully running for over 5 years now, sharing best practices in the field of neurology. So let me not stand between you and our speaker today. And I take this opportunity to introduce Dr. Arvind Sharma to this very diverse audience. Ladies and gentlemen, Dr. Arvind Sharma is currently the head of the Department of Neurology and Stroke Specialist at Zydus Hospital. In fact, he has been instrumental in installing a very robust framework for the management of stroke in not only at Zydus Hospital, but across various centers throughout the country. Dr. Arvind Sharma is an assistant professor of neurology at NHL and SVP Hospital, Ahmedabad. He is also the secretary of the Indian Stroke Association and very recently elected as an executive committee member of the Indian Academy of Neurology. Another very important specialty for which he has carved his own niche is the field of neurosonology, and he's also the founder member and vice president of the Society of Neurosonology in India, Ahmedabad. Last year, he was elected as the board member of the World Stroke Organization, which shows his commitment towards improving stroke care, not only in India now, but across the world. He's a council member of the Asia Pacific Stroke Organization, and he runs a foundation known as the Brain Heart Foundation as a director, which not only helps the doctors, but also to patients to understand what lies beneath stroke and atrial fibrillation. He is also a member of the Quality Accreditation Institute, the Technical Committee for Stroke Accreditation. Sir, I think we couldn't have found a better speaker for this topic than you. And let me now hand over the session to our speaker, Dr. Arvind Sharma. Welcome, sir.
Thank you very much, Hardik, for that wonderful introduction. And I hope the talk which you have given to me, I'll make justice to that. Very well said. Stroke is very much close to my heart, and I definitely love to spread awareness about it. And I welcome all my colleagues across the world to be part of this presentation, and would love to learn from each other about the stroke-related epilepsies and stroke-related seizures and epilepsies. So without wasting much time, I'll take 20 to 25 minutes to go into the how stroke and epilepsy are related. And I think, Hardik, I'll ask you, you can see the slides, right? It's you can
yes,
see
I'll just request. Yeah, perfect, sir.
Yeah, you can see this. Yeah. Fair enough. So, and I'm audible, right? That is the two things I want to know.
Sure, sir. You're audible loud and clear.
Yeah. So, yeah, thank you very much. And we move forward. How the natural history and the main process of care occurs in stroke. You may be a epileptologist, you may be a movement disorder expert at your place, you may be a neurophysician who are practicing all the diseases. And most of us are a neurologist and an internist first, like we are the medicine people. So as soon as we know that stroke comes to you, we time is brain, we do the reperfusion strategies, we do different procedures for that. There are various point of time where the epilepsy is there in the natural course of the stroke. Even when the patient present with the stroke, they sometimes present with the seizures. We all know about it. And there are many stroke mimics which are like a seizures, and subsequently when you see, they turn out to be strokes. So if you see in the complication and at the discharge, you see the various complications of the stroke. Patient, if it has a very severe disabling stroke, they can be bedridden, infection, cardiac complication, recurrence. And seizure is one of the part which is very important to know about when we are discussing any point of time about stroke. And we know while we're doing the rehabilitation, there are a lot of depression, fatigue. That is what the natural course of stroke is. We are not here to talk about stroke because, but we should know that from the ER till discharge and post-discharge, there is always a looming threat of having a epilepsy or a seizure post-stroke. So if you go back to the history, it is described long back by Jackson century ago. And if you see how the epidemiologic events occur and how it goes in the subsequent time, the post-stroke epilepsy, you call it when they are late onset seizures or there is a spontaneous recurrent seizures. So the seizures which occurs with the stroke, presentation of the stroke, they are very early seizures, and they can be because of the provocation nature. They are known as the provoked seizures when they present at the ER with the stroke. But as you pass, there is a damage in the brain. You will call it as a symptomatic epilepsy or the scar epilepsy once you go more than 2 weeks of the stroke. There are different definitions for the early seizures and the late onset seizures. There is a lot of guidelines which are gray areas, which we'll discuss here. You may have a different pattern of the early seizures or the late onset seizures. So if we go to the epidemiology, the most common identified etiology of secondary epilepsy, 11%. Stroke accounts for 30 to 50% of newly diagnosed seizures in greater than 60 years. And 2% rate of the post-stroke epilepsy, median of 9 months in one study, and 4% in 2 years. The Oxford Community Stroke Project, you know about it, the cumulative risk, what they have seen for 5 years is 9.7. Many different definitions I was talking about, that early and late. Here I have taken by the International League of Epilepsy Association. I'll discuss further in my slide. Hence, the uniformity is lacking. So frequency of the early post-systemic seizures, 2 to 33%, but after within 24 hours is 50 to 78%. But the late frequency of the late post-systemic seizure, it ranges very high from 3 to 67%. So I'll quote one of the Indian studies in the subsequent my slides by Ayush Agrawal et al. From AIMS, that is 12.7% of incidence of the early seizures. So post-ischemic stroke epilepsy, that is the secondary epilepsy or the symptomatic epilepsy or the stroke epilepsy, if you see in the late onset, it's 2 to 4%. And the early seizures are at the independent risk factor for the late seizures and epilepsy. If you have an early seizure in any stroke, there is 8 times more likely chances of the late onset seizures, and 16 times the patient can have the epilepsy. So late seizures are also independent risk factor for the epilepsy post-ischemic. So seizures that occur after a stroke with a previous history of the epilepsy, I don't think this audience is need to be tell about what the epilepsy classification is. Right, we all know about the idiopathic generalized epilepsy, and we are not talking about the people who have epilepsy from before and they subsequently are not in that category. So we are talking about the seizures that occur after the stroke without any previous history of epilepsy. And we know when we do an EEG electroencephalogram, we can do the localization of the epileptic discharge according to the type of stroke or the damage in the stroke. We'll talk about the cortical and the subcortical nature of the stroke and what are the site. Is it a large vessel occlusion or it is a cardioembolic stroke, where the frequency of seizures are more, where the seizure frequency is less. This is all the talk is all about. And subsequently, we'll discuss about the management part, what you should do if there is no seizures and stroke happen in those locations, which is the question I think everyone, even I'm looking at, and we'll discuss that part in the question and answer. Developing seizures after severe stroke was linked to the high risk of death and disability, no doubt in that. We'll talk about more about the prognostic factors in the subsequent slide. As I was talking to you, International League Against Epilepsy has divided early seizures less than equal to 2 weeks after the stroke, and the late seizures occur greater than 2 weeks after the insult. Early seizures alone not sufficient to diagnose epilepsy because they are provoked. If there is a cortical involvement, the patient can, like the right-sided strokes or the cortical strokes, when they may present with the epilepsy. The single late onset seizure qualifies as a symptomatic seizure due to the high risk of the seizure recurrence within the next 10 years. If you see the burden of seizure in patient with stroke, 5 to 21% have shown that up to 1 in 5 patient with stroke will develop seizures. 1/3 of the patient develops seizures within 24 hours of stroke, and 50% within 30 days of the stroke. what the epidemiology of seizures is being. And further, as we describe the type of stroke, if it is cardioembolic or is a large artery atherosclerosis, you can see the large artery atherosclerosis, the focal with the bilateral spread is more. And in comparison, if you see, the generalized seizures are more in cardioembolic stroke. So the type of, as we are discussing the type of seizures, if you see the awareness of the symptom of stroke, you know about how people go to the different specialists for a stroke. Like one of the example I will give you about the stroke is the sensory aphasia, where there is a circumlocution, jargon speech. People go to psychiatrist to see that he is not able to speak. So that is how you can see for the seizures, up to 63% of the seizures may not be recognized by the patient, and which is very important to spread awareness about the do's and don'ts and how the seizures can be. They are not always the generalized and tonic-clonic. They can be simple partial seizures. They can be complex partial. And if you see the early seizures, 50 to 90% are the simple partials. The complex partial seizures are highly unrepresented because there can be only aura, can be only abdominal discomfort, some automatism can be there. So 15% of those partial seizures are aware of their spells. General seizures may account for 25% and with a high stroke volume, and 0.8% of the patient have the acute stroke, ischemic stroke had a symptomatic epilepsy, 0.9% in the population study. If you see the seizure-free survival by level of disability in the post-stroke, the lower rate of seizure-free survival are seen in the high level of the disability after stroke. I will correlate with the NIHSS for you, that is the severity scale. If you see, I will correlate the stroke and epilepsy with the MRS. So the severe stroke, the seizures, low rate of the seizure-free survival. Seizures were significantly associated with the moderate to severe disability. Pathogenesis, as you see, the idiopathic generalized epilepsy is totally different. As you know, the stroke, when it occurs, there is a lot of inflammation is there, and there is a glutamate release, which is excitotoxic. And then subsequently, there is a cell death. But as you see in cardiac, we have a synaptic remodeling for all the structures of the brain when they are damaged. Then there is a neurogenesis. And we all talk about neuronal plasticity in stroke, where the recovery also happened because of the remodeling. But there are chances of epileptogenesis during the same time. So that is what the post-stroke epilepsy is there. Because the neurons, they also misfire, what we call it. And sometimes they help the people to have the neuronal plasticity, and the opposite side of the brain takes the part in it. But they can also be responsible for the post-stroke stress epilepsy. So mechanism is slightly, there are a lot of pathogenesis has been said for the early seizures because they are more, I will call it as a provoked seizure. The long-term treatment for those early seizures are not warranted, but definitely you have to observe all the parameters, and we have different score, which we'll talk about in further. Glutamate is increased in the extracellular milieu, as we discussed, because of the excitotoxicity, and there is a significant evidence of the role of glutamate in initiation and propagation of the seizures and in the process of epileptogenesis. So delayed seizures are different from the early one because there is a structural damage occurred because of the clot there and because of the damage of the area where the blood has not reached. Those are lucky who have reached in time. Now the thrombolysis and the thrombectomies are like this. You have a very little damage in the brain, but we'll talk about the occult strokes also, which can lead to vascular dementia, but they can lead to stroke epilepsy also. That we'll discuss in subsequent slide. If you see, there is thrombin and the clot, and there is a maladaptive plasticity which generate the epilepsy. So delayed seizures are because of the permanent structural damage. There is a shift in the regulation of the neuronal firing, lead to circuit dysfunction, and there is a coagulation cascade which is affected, that is particularly thrombin, and the protease activated receptor 1 involves independently to develop a maladaptive plasticity. And the result of that of neuronal firing and the maladaptive plasticity, the delayed seizures have a high recurrence. So if you, as we were discussing, now we come to the main part. after the epidemiology and the pathogenesis, risk factors. Ischemic stroke subtypes, definitely. Location, stroke severity, and age. There is a high risk of epileptic seizure in hemorrhagic stroke. You know about as SAH and the cortical focus of ischemic. Infection, lower performance on NIH and MRS, and the lower premorbid functional state. And if you see this, one of the studies which I've done in the 3,310 patients, the post-stroke epilepsy with risk continues increase outside the active phase, young age, cortical location, larger lesions, and hemorrhagic lesions are the independent predictor if you see in the conclusion. Seizure and epilepsy after a stroke, the biomarkers and the management, these are the other implicators. Hypertension, smoking, alcoholism, infection preceding stroke, elevated cholesterol may be protective, which has been said. IV TPA, you know it is neurotoxic, and sometimes you have seen the patient in your life when you give a TPA, patient develop seizures at that time. But the prognosis is not bad. Those are more provocative seizures and they are in the acute and onset. Use of antidepressant, antipsychotic, and anxiolytic. And all of this, I will include the metabolic parameters also, which happens in the first week of the stroke, when post-stroke, the sodium and potassium, when it goes down. Genetic predisposition, definitely there is a high level of the plasma of the CD40. Both are the prothrombotic and the oxidative stress. If you see the beta oxidation, which we talk about the biochemistry, we are definitely always excitotoxic. And there is significant role of the T allele of CD40. So post-stroke epilepsy is associated with the polymorphism of the interleukin-6 gene also. So the risk factors for seizure and stroke, if you see, if in a progressive manner, if you see you can see my cursor, the odds ratio is the highest for the NIHS is greater than at the admission of an acute non-neurological infection. You see if the MRS is 3 to 5, there is a very high risk, previous stroke, patient is on anticoagulation, age, and least for the diabetes and antiplatelet and admission. More seizures are reported. If you see, this is what the lower down the NIHSS is. If it is more the NIHS, you have the higher the number of symptomatic seizures. So early post-stroke seizures in acute ischemic stroke, as I was talking about in the first two slides about the Indian study, this is done by the Ayush Agrawal at the AIIMS with the various other professors. If you see the conclusion in this also, in the study which they have done almost from June 2018 to May 20, where they have taken the amount of the patient, total amount of the patient, they have taken 432. They concluded in the sense the early seizure prediction was on the following component. That is the cortical location, large vessel stroke, MRS, anticoagulation use, and presence of hypertension. So these are the tool might help in treating patients with high risk of early seizures with prophylactic ASD, thereby prevent seizures and their complication. But this statement is a very big statement. No one of us uses an anti-epileptic definitely as a prophylaxis for these components also. They are the markers where you have to be very cautious. In that, I will label the cortical location as and large vessel occlusion at a very high level. So if you see the multivariate analysis for this, they have labeled the odds ratio for cortical location highest. Then if you see the anticoagulation use was there, large vessel disease was there, hypertension, age, NIHSS, and MRS. These were the multivariate analysis where they have kept the cortical location at the highest. Post-stroke epilepsy risk scale, the POSER, they have given 2 points to the supratentorial, ICH within the cortical areas, 2 points, ischemic involving the cortical and subcortical areas, ischemia with the non-neurological deficit, 1 point, and stroke with the greater MRS is 1, and seizure occurring within 14 days, 1, and occurring 15 days or later, that is the late onset 1. Opposed to they have kept it 2 because the recurrence is very high in these cases. Another prognostic model where they have got the mnemonic select, they have got from the severity of the stroke, large artery atherosclerosis, early seizures less than 7 days, cortical involvement, and the territory of MCA. The territory of MCA 1, cortical 2, early seizures they have 0.3, and large artery 1, and severity of stroke, if the NIH is greater than 11, it is 2. So highest select point is 9, and more than 80% of the risk of epilepsy within 5 years of the stroke if the level is so high. And we can predict by the select value how much of the risk up to 5 years of the stroke. If you see at the level of the select numbers goes up to 9, it goes up to even 60 to 80% of the chances of epilepsy. Another prognostic which is very important is the K for the late onset seizures. We have talked about the Indian study for the early onset seizure, where the prophylaxis they have discussed about. This is about the late onset seizure. The K, that is the cortical, is 1 point, age less than 65 years, 1 point, volume greater than 10 ml, 1 point, and the early seizure, 1 point. So that's a 4-point system. And what I want to say about the post-stroke epilepsy, that the stroke severity is the most important determinant of the outcome. An early seizure in the penumbral area might be harmful. The high mortality rate at the 48 hours had been reported, and significant impact of the severity of the stroke and the disability not substantiated. So late onset epilepsy and the occult cerebrovascular disease. As we talk about the vascular dementia, this is also a great help where you find a silent stroke presenting with no symptoms in the non-eloquent area, but they can present as a late onset epilepsy, where the patient asks you, why have I suffered epilepsy when I don't have any side effects? I don't have any metabolic parameter derange. I don't have any sodium low, or there is a hypocalcemia. Why I suffered that? So this model is very important to understand that how the latent or the occult cerebrovascular disease or strokes can cause late onset epilepsy. I'll take 5 minutes on this. There is a comorbid clinical state where you have a subcortical ischemia, you can have a small vessel disease, you can have silent cortical and subcortical infarct. And I will label the small vessel disease very high in this category for the stroke. There is PRES, there is RCVS, there is a cerebral amyloid angiopathy. These are all, if you see, there are the overlap of the rings where you can have epilepsy. And MELA is the mitochondrial disease, and vasculitis and CADET-cell, CADET-cell present with the migraine. So these occult strokes or the cerebrovascular disease, they cause a disordered cerebral metabolism and perfusion. There is inflammation. There is a blood-brain barrier dysfunction, hemodynamic dysfunction, loss of the neurovascular unit integrity, extravasation of the serum protein and cytotoxicity. And subsequently, they have the same pathway of hyperexcitability, neuronal injury, and disruption of the neuronal circuit. And ultimately, they can cause epileptogenesis. I think this is becoming a more and more increased burden as more and more MI and stroke are happening, which are unknown to the person, and they are not screening themselves for the carotid. As you see, we talk that most of the people, they only talk below neck. You also in your countries maybe have felt there is a cardiac checkup, there is a general checkup. How many of you at your country have a stroke checkup for you or a brain health checkup? Nobody goes above the neck. Nobody does a carotid vertebral Doppler as a screening. They all do echo, 2D echo and TMT. So I think this is also a brainstorming to know about how the patient can develop in subsequent years if there are silent infarct, how we can prevent them from having the epilepsy or the dementia. So last 5 minutes for the Hardik, you can stop me anytime if I'm overshooting the time. And if you are okay, I'll go further.
Sure, sir. Please take your time. Please.
Yeah. So management of seizure will take another 5 minutes, and then we can discuss with the question and answers. The management of seizure in stroke patient, single early seizure treatment as they are the provoked seizures. Just if patient present with a seizure to you, right, with the stroke as a cortical stroke, treatment may not be necessary. But recurrent early seizures and the late onset seizures need to be treated. There are some concern about the phenobarbital and benzodiazepine may impair the post-stroke recovery. And we know what are the side effects of these drugs. We know how benzodiazepine and carbamazepine, they can lower the, carbamazepine is a very notorious drug to cause various metabolic disturbances in the blood profile. So recurrent seizures, the class of recommendation is 1 and level of evidence is there. So they have to be treated with the anti-seizure drugs and should be selected on the specific patient characteristic. So European guidelines also say the same thing for the treatment of the stroke as an antiepileptic drug. But if you go in these guidelines of AHA and ASA and the European one, there is very insufficient evidence for the primary prophylaxis with an antiepileptic drug to prevent occurrence of the seizure and stroke. I think we'll talk about it. There is only one study I found from our Indian setting where they have discussed the risk factors like the age, the cortical involvement, but they have not proposed that prophylaxis to be given or anti-seizure drug to be given as a primary prophylaxis to the stroke patients. So there is a very insufficient evidence, and this is the only gray area where they may suffer, but there is no definite guidelines to start the anti-epileptic. So lack of reliable randomized control trial, the non-negligible side effects of poor outcomes in some studies. Most of the data on the basis of the older antiepileptic hold the newer antiepileptic drug can change the guidelines, because the drugs which were very popular and they are very beneficial, I agree, but they have a lot of side effects, which you talk about the generalized drug which we are using before, and the new gamut of the antiepileptic which have come, which may change the scenario. So patient with acute stroke, primary prophylaxis is big no. Symptomatic seizures, immediate therapy with the antiepileptic drug, and delayed treatment with antiepileptic drug. So early treatment of seizure in patient with stroke, first seizure. If patient has presented with the first unprovoked seizure with no significant high risk for recurrent seizure, antiepileptic should be deferred until the recurrent seizures occur. And this is same for the first seizure, which we talk about with other etiologies also, that we should treat or not to treat. That is what to be or not to be, like Shakespeare, right? However, the stroke-produced structural lesion, we know risk of recurrent seizure varies. Immediate anti-epileptic drug use is still unclear, and treatment with AD depends on the clinical situation. And I tell you, we should go on the clinical situation of the patient. So what are the early treatment of the seizures, and what are the chances of such patient to have a second or subsequent seizure? When patient present with a second seizure or the unprovoked recurrent seizures, the anti-epileptic drug should be initiated, because the risk is additional seizure is very high. So when you have a second one, if you see that there are 55%, 57% chances of in 1 year, and 73% by 4 years. So patient with second seizures or recurrent seizure qualifies as a post-stroke epilepsy, and you should treat them as you treat other forms of epilepsy. And if you see a flow chart, symptomatic seizures, immediate therapy with anti-epileptic drug. Early seizures, they are provoked, may not warrant multiple. Definitely the short-term 1 month with the anti-epileptic drug to prevent the long-term seizures. We'll discuss about the time duration. I have the slide which I have proposed for the early seizures. But if you see for the delayed treatment with the AADs, late seizures, you treat them as the same as you treat the other anti-epileptic, other epileptic patients, and you continue them for 3 years. And then you have to see the survival, maybe up to 5 years in some cases. Now, there is no holy grail for this, that how you select the right AED. There are variables. When you treat a patient, there are different variables. There is a lot of drugs patient is on in stroke, where you see for the pharmacokinetics, pharmacodynamics. If it's a pregnant lady, you talk about the teratogenicity, and the young reproductive female, you talk about in a different way. You don't use valproate in PCOD. There are different variables which are there: genetic factors, age, gender, concomitant medication, ability to swallow. So availability of the anti-epileptic drug. We recently did a neurospace in Vietnam, and I think some of my friends will be here. And we talk about a lot of anti-epileptic drugs present in their hospitals. So one of them came as we have intranasal midazolam at our place in India. So there were a lot of countries where the nasal midazolam is not being cleared by their local regulatory bodies. So it depends on the various variables for treating the patients. So, but if you see the managing the acute symptomatic seizures with the second one, we have already discussed about the how the risk is there for the first year and the second year, and how the delayed seizures with the conventional long-term anti-epileptic treatment and the post-stroke status epilepticus, you treat any patient you treat like a status epileptic patient. This is about the Chinese Stroke Association guideline for the clinical management of the cerebrovascular disorders. And I think this goes similar to what we presented with the European and the AHA guidelines. And they also say that anti-epileptic medication is not recommended for the long-term use of the epileptic control in the isolated episode of the acute seizure. If you see the first line and the second line therapies, which are mostly used, and I collated with the meta-analysis, the most of the drugs which has been used is the levetiracetam and the lamotrigine. We all know the side effect profile about the levetiracetam. When it came like a drug, there is no side effect. Then we know the somnolence is there. We know there is a psychotic phenomena is there. There is a suicidal tendency is there. But hyperammonemia is there. Lamotrigine, we all know about Stevens-Johnson syndrome. But they are the new generation drug, and they are a better drug tolerance. If you see the older generation of drug, where if they are effective, we can use them. But these are the drugs with stroke has a very less side effect. If you have a patient with CLD, you can use a levetiracetam. And if you have a kidney patient, you can use a lamotrigine because it goes through the liver. So older studies has used other conventional and comparable efficacy superior tolerability in comparison to carbamazepine. I definitely agree about this point. I will take your views also on that about the carbamazepine. It has sometimes become very notorious with stroke where the tendency of hyponatremia is very high. So if you see the arm here, the most popular drug is levetiracetam, and the further congener has come in India, that is the brevitiracetam, where this all psychosis and is gone, and we are using them as a drug in the post-stroke epilepsy. And monotherapy was prescribed in 93% of the patient, and out of that, 55.3 uses the levetiracetam, and you can see the percentage of the various other drugs which has been used. What are the current perspective and diagnosis in the treatment? Since most of the partial seizures, the carbamazepine and gabapentin is the first in adult, and if you see the most effective with the lesser side effect is the lamotrigine, and levetiracetam is better tolerated. And if you see in the children, the levetiracetam is the most common, and both levetiracetam, lamotrigine go side by side with the more side effect, they say, with the levetiracetam. So adult onset, most patients required only one at the end of the second year, and up to 67% seizure free by the Stephen et al. At 2001 trial. And seizures are most resistant in the pediatric population. And I don't know why, but this is true. We have seen also. And the lower doses of phenobarbital may be protective against the consequence of ischemia that was seen in the bench trial, and also reduce the seizure and the chronic brain injury. So when to withdraw the anti-seizure drug, anti-seizure medication? So here the question comes, which will be a discussion point with among our all fellow colleagues and the expertise, at about 3 months for the early seizure. But how you stop it? Do you taper it, or you just stop it like this? This is a question with all the audience, and I would also like to answer. Or you do an EEG to such patients and then you taper and stop. And late at about 2 years of the seizure-free period, you evaluate and manage as with any other epilepsy. For our here, we took 3 years for such late onset symptomatic seizures, scar epilepsy. Sometimes they are very notorious, and patient can go in status, don't reduce the drug immediately for the post-stroke epilepsy. I really thank you for your patient listening, and I'm happy to answer all the questions. And I really thank Zydus group to give me this opportunity. They are like family to me. I really thank them to giving me this opportunity for this STAR program and sharing my views on stroke-related epilepsy. I thank Hardik, Sharad, and all the Zydus corporate group for giving me this opportunity. And thank you very much once again.
Thank you, sir. Thank you very much for your very succinct presentation on this topic. I think your presentation has really clarified a lot of doubts and also highlighted the current state of evidence on this subject. But as always, we have a very curious audience who has a lot of questions. And therefore, with your permission, I would like to, ask a few questions on behalf of the audience.
Sure, sure, Hardik.
Sir, I think the most common question which I was expecting is repeated 18 times in the comment list is about primary prophylaxis. And you have shared in the presentation that the current guidelines do not recommend primary prophylaxis at all. But considering your practice in India, and while the global perspective and the global guidelines do not currently have a recommendation for primary prophylaxis, what kind of patients would you initiate primary prophylaxis when they present with an ischemic stroke?
Very good question, and I expected this question to come as first. And you had made that point very clear that this question will be there as the top one, and that is why I presented that. I went through different studies across world, and I discussed with the AIMS guys who has done those study in the primary prophylaxis. I spoke to one of the investigator in that, and I tell you, our practices, what we do here in India, and I think I will agree to most who are working across world in epilepsy. The most important factor is the cortical involvement. If there is a cortical involvement of the stroke is there, and you see there are very high chances. Another is the thalamic involvement, where you have a thalamic bleed, right? These are the two areas where the chances of the seizures are very high. So such patient, if they come to like thalamic stroke, they come to you with unconsciousness. So sometimes the EEG of 15 minutes can be normal. So in those cases, I start anti-epileptic drug because thalamus itself is a reticular activating system. Patient come in a very drowsy state. So the explanation, is it because of the thalamic stroke or it is a seizure? You sometimes don't know about it. So for such patients, we definitely start them on the prophylaxis. Large vessel, not much. Those all are relative, but definitely there are, if there are multiple stroke different areas, like as I talked about the occult CVD, right? There are multiple infarcts altogether there, and patient is not becoming conscious, and I'm not understanding the etiology for patient not coming out of that consciousness. I'll definitely think about that.
Right. Sir, a follow-up question to this is, while you did show evidence on which kind of drugs to choose from, and I think given the current state of art, lamotrigine and levetiracetam may be the drugs of choice. But now you have some experience with using brivaracetam, and also perampanel and oxcarbazepine have shown some evidence. There are some papers reflecting their use in post-stroke epilepsy very clearly. So where do you find the use of new drugs, and how do you think they are going to replace the second generation drugs like levetiracetam and lamotrigine in the future for post-stroke epilepsy in particular?
That because as you start using the drug, you start seeing the more and more side effect of those drugs, and you want your patient who are already suffered from the stroke, when they go into the post-stroke era, they develop depression, fatigability. So you want to have a drug which is effective not to have the seizures, but they don't affect their quality of life also. So the talking about the drug which you talked, the brevitaricetam, and after using it, if you see with the levetiracetam, I tell you, it's a wonderful drug. But when it comes to for the suicidal tendency or psychosis or somnolence, brevitiracetam take all the side effect out from that. What we have seen, right? And it is the renal clearance if you want to give, because as you work in a tertiary care center where the stroke patient are coming, you are doing thrombolysis, thrombectomy, and you see there a patient is a CKD all on the, so brevitiracetam clearance is much better, and nephrologist is more comfortable on such drugs. And having said that, using a new drug, most important thing is that they should be seizure free. So we have seen in from last 5 years, we are more than 5 years, we are using, I think since the launch, we are using brevitaristetam now, what I remember of 4 or 5 years. And they are equally effective what levetiracetam and lamotrigine is. And the second drug which you are talking about, that is the parampanel, sorry. The parampanel drug is very effective in the focal seizures. Though partial seizures, it is a very effective drug. As an add-on, it is a very effective drug. So those who present with the symptomatic epilepsy, sometimes they don't present as a generalized seizures. They may present as a complex partial seizures too also. So these drugs are very effective in that manner to us. Sorry, I've not concluded with the oxcarbamazepine. So oxcarbamazepine is also a very good drug. Only request to all my fellow friends is that we have to monitor sodium with stroke in that. That is only the factor. Otherwise, we all know that carbamazepine is a drug of choice for all the complex partial seizures and the focal seizures what we have.
Right, so thank you for throwing light on that particular bit of measuring sodium. Sir, one very interesting point you mentioned about jargon speech, and I think the question is coming from there. It's a question from Myanmar. The question is, are there, like jargon speech, are there any other signs and symptoms of seizures which may be missed by the physicians?
I think I have not, because of the time constraint, I have not given that whole scenario. I will explain my fellow friend about it, right? He has very rightly pointed that is the patient presented with a complex partial seizure at the time with the ictal speech, or it was a stroke. So this patient which I am talking is a 30 to 36-year-old male, obese. He's the CEO of a company. So he seizure, it happens for a moment, for seconds, or a maximum a minute. But this patient was not able to express himself. When you ask him a question, where you live, he talk about in the different area, my name is this, I'm going there, I'm this. He doesn't go answer that straightforward, and he circumloculate as a jargon speech, because he was having a fluent aphasia, right? And he went to 2 psychiatrists and took clonazepam from 2 psychiatrists. Then we came to our hospital looking for a psychiatrist. And subsequently, when we saw it was a sensory aphasia for that patient, if it would have been the seizures, it have been happened and stopped, and then the frequency cluster of attack may be there. If it is persistent, having a jargon speech, that is more a sensory aphasia, we found a parietal stroke for this patient and subsequently treated with a speech therapy. And after 3 months, he was able to join the job. So the differentiation between the jargon speech for few seconds and minute, that can be a ictal speech and can be a complex partial seizure. But if it is persistently present, you have to look for a stroke for such patients.
Very interesting. Sir, there are some questions on the pathophysiology part also, but before that, while we are talking about treatments, one question is, are there any new treatments or interventions on the horizon which may not have been yet approved, which you think will be very important for stroke survivors to prevent epilepsy? I think this is a very, very forward-looking question.
Yeah, it's a very promising question, and very rightly put, in the world subsequently will be treated. So the treatment, I will take it in different way. We'll talk about the prophylaxis first. I think it is, you have to see, I would suggest you do an EEG to look for interictal discharges. If you find an interictal, select criteria, the different criteria, the Poser criteria, you do those criteria and do an EEG in them. That is one. But there are strokes which can present with the refractory seizures, like seizures which are not being able to treat it by the 2 drugs, 2 seizures every week for 2 years you are not able to control with the drug, there are treatments which are there. We can call it they are more invasive, like which is post-stroke. But I think these are the parameters to take those select criteria, do the EEG and know about it and treat such patients. There are gadgets. I have gone through devices when I was doing one advisory to one of the latest devices for internationally, where they have shown that the continuous EEG monitoring, but that is a very futile exercise to go for 24 hours and put the patient after the stroke in such conditions. And let's wait for the future, right?
Thank you, sir. So, sir, talking about interventions, I think one very important point we discussed earlier was about decompressive craniotomy and craniotomy, sorry. And for patients with a malignant stroke, of course, this is like a reserved or a last line of option which is offered to the patient. What do you think is the impact of such decompressive craniotomy or hemicraniotomy on seizures?
Dr. Hardik, I tell you, we discussed about it, and it is a very good question in the sense it is nowadays not a last resort. I'll fully describe that, because now things are changing so fast, and my fellow friends and colleagues will agree that early decompressive craniotomy main stem MC occlusion is recommended in first 48 hours, and all the trials which have shown within a week, opening those brains which swells and have a large artery occlusion and having a more than 1/3 or 2/3 of the brain involved, because there will a lot of edema, to open them with a large bore of the skull to be removed, they are less having a post-stroke epilepsy than not doing any surgery for them. As you have seen, the large stroke, they have more chances of epilepsy. And if you don't decompress them, the prognosis is not good, in the form of they will be more in a vegetative state. And there is a chances that they may able to walk with the decompressive craniotomy. That is one. Second, there is a latest guidelines has come. Those you think is a large vessel, even after presenting after 24 hours, you open up the artery and then do a decompressive craniotomy. So that is the latest recommendation. Even you open the artery, because it comes with a huge cost. You open up artery, that is a cost, and then you do a decompressive craniotomy. It's a huge, long process. It is a bad stroke where you want to keep the patient alive, but it is much better than the vegetative state. From MRS 5, if you bring the patient to MRS 2 to 3 also, you have done a great justice to the family and the patient.
True, certainly. I mean, improving their prognosis is really important. And if the correct form of a therapy or intervention is chosen, certainly the overall quality of life is also going to improve. Sir, one question on neuroplasticity. I think you briefly touched upon this point on neuroplasticity and epileptogenesis. And the question is basically, while neuroplasticity is a normal recovery process following a stroke, why does it often lead to development of epilepsy, or why does it contribute to epileptogenesis?
So, very good question, right? See, it is just like a trauma, right? It happens to the brain, and the area goes totally without the blood supply, no oxygen to that part of the brain. Initially, if you treat during the penumbra time, where there is a benign oligemia, you save that area. But as soon as the blood supply stop to the brain, certain area of brain will form a core. That is the permanent damage area of that brain. So the permanent area of brain which is damaged can be eloquent and non-eloquent area, which is used for the functions or maybe not used for the function. They are for the synaptic regions. But as they tried every structure of the body to the cells molecule, they have a tendency to recover. So when they recover, the glutamate, the chemical reaction, as I shown you, there is a maladaptive plasticity happen. So there are positives, there are negative for the plasticity. If it is on a not maladaptive, it will help you to develop the function again. So your spasticity will reduce, your function will improve, you will do good. But it goes to the maladaptive plasticity as you are doing a neurogenesis as a natural process, and it may happen that it goes to more towards the excitogenic potential and can develop a seizure because it is electrical activity, right? Just heart when it is recovering, you see that it fibrillate more. The arrhythmias are more when the cardiac remodeling is there. That is why the cardiac people, the cardiologists are more worried when there is an anterior myocardial infarction. They do remodeling, they do exercise, and they do things. And that is why our physiotherapy is also important when there is a neuronal plasticity happening for those patients.
So very interestingly, I have a follow-up question to that. Is thrombin is also involved in neuroplasticity? In one of the figures, we saw that thrombin contributes towards neuroplasticity, and ultimately it may lead to epileptogenesis. So, do you think inhibiting thrombin with the use of drugs like apixaban or rivaroxaban at this stage might contribute to reducing the incidence of epilepsy? And I think the paper by Ayush Agrawal, where they had the scoring, they also used anticoagulation as one of the scoring points. So, what is your take on that?
Absolutely. See, when or the stroke, see, the clots are different for the cardioembolic. Clots are different for the artery to artery. They are the atherosclerotic clot are more hard. So you need different drugs for them. You need to open them, right? So it depends on the mechanism of the stroke. So if it is more thrombin bound, and if you are using a direct thrombin inhibitor or the factor 10A or any anticoagulation which you are using, definitely will be beneficial. But having said that, you have to very judiciously use them to prevent any kind of bleed in the brain. That is also important. So you have to take the clinical condition and what is the mechanism of stroke, why we are giving the anticoagulation in such patients. But definitely they are helpful.
Thank you, sir. I think in the interest of time, we will conclude this discussion here. And at the end, I would like to thank you very much for taking the time to not only work with us towards developing this whole concept, where I think we have been able to share a lot of best practices and learnings in the field of stroke related seizures and epilepsy. You've highlighted not only how the epileptogenesis follows in a patient with stroke, but also given some very good guidance on managing such patients in different clinical scenarios with stroke mimics, seizure mimics, etc. And I think the audience will take back a lot of important lessons. Sir, I think we have close to 150 doctors present with us right now, and a lot of comments are coming in. Not only questions, but some favorable comments thanking you for this session as well. So, on behalf of all the audience and Zydus, I thank you very much for taking your precious time to deliver this talk for us.
I thank in an Indian way, I do namaskar to all of you. Thank you very much for the patient listening. And I learn, I think you can share the email ID, Hardik, for any further
Sure, sir.
question. We can touch base with each other for more insight and learning. And I
Sure,
thank you
sir.
all.
Sure,
Thank
sir. Thank you, sir. Thank
you
you.
very much.
And to the
Thank you.
audience, I'd just like to share one more thing. Is we were talking about anticoagulation, and we have recently started a survey on initiation of anticoagulation. So I'm just going to share my screen for you to scan the QR code. And this is a survey about anticoagulation timing linked to appropriate stroke care. We are calling this the Atlas survey. which we have designed with the help of our speaker, Dr. Arvind Sharma, and a very senior stroke researcher, Dr. Vijay Sharma from Singapore. And currently, this survey is open, and we request you to take this survey and answer the questions on this survey. The survey is about your current understanding of initiating anticoagulation in patients with different severity of ischemic stroke, particularly present with comorbid atrial fibrillation. Once you open the survey, you will find more details based on this QR code. And we look forward to our subsequent webinars to share more details from the results of this survey as well. So that's the ending of the program today. I thank all of you who have taken your precious time to join this survey. And we look forward to announcing the date of the second webinar in this season 2 of the STAR webinar very soon. Our teams in your respective countries will let you know. Thank you for joining today.